What if I told you that cancer could be the best thing that ever happened to you? I'm Joelle Kaufman, and after 4 decades of cancer experience across 3 generations of my family, I've learned something most people won't tell you about this disease. Right now, as you're listening to this, someone just heard the words, "You have cancer," for the first time. In the next hour, 230 more people will join them. But here's what nobody tells you about that moment. It's not the end of your story. It's a beginning. It's a beginning of discovering just how powerful you really are and just how innovative treatment has become. Welcome to Kicking Cancer's Ass, the podcast where we explore how life's curveballs become catalysts for connection, power, and joy. Each episode brings you insightful interviews with leading innovators transforming cancer care and people whose lives are transformed by their cancer journey. You'll be motivated, you'll be inspired, you'll be amazed. This is where all of us, whether we are facing cancer or not, rewrite the narrative from victim to victor, from surviving to thriving, one curveball at a time. Remember, you're stronger than you think, and you are definitely not alone. And welcome to Kicking Cancer's Ass with Joelle Kaufman, the podcast where we rip away the whispers and fears surrounding cancer and replace them with power, strength, joy, and actual useful strategies. So I'm your host, Joelle Kaufman, and today I have a guest that I genuinely adore. My guest, Dr. Harriet Borofsky, was my doctor for over 20 years. And how many people have a close, friendly, joyful relationship with their breast imaging radiologist? I don't know, but if you got to have Dr. Harriet Borofsky as your doctor, you'd want one. Dr. Borofsky built the Women's Health Center in Northern California that actually found my tumor. Today, we're going to talk about some uncomfortable truths about breast health that maybe the medical establishment glosses over, and we're also going to learn why women should embrace the opportunity for screening and early detection. And mostly, I'm just thrilled to introduce you to my doctor and my friend, Dr. Harriet Borofsky. Harriet, thanks for being on the podcast.
Thank you so much, Joelle. It is wonderful to be here. Wonderful to see you. I am privileged to know you and to be your doctor and to have a connection and history with you and your family. For very many years, I remember the first time I met you. And of course, I'm very excited to be here to be speaking about what has been my professional passion for the past, dare I say, 3 decades, early detection and diagnosis of breast cancer.
To fill in some of the blanks, I met Harriet when I was 40 weeks pregnant with my second child. I think the day or the day after we found out that my 29-year-old sister had just been diagnosed with a triple negative small tumor. And I show up at the breast imaging center, enormously pregnant, and Dr. Harriet comes over to me with exactly the same energy and positive enthusiasm and says, "Don't worry, I have a big lead apron and we're going to take some pictures and do some scanning. We're going to do a mammogram and an ultrasound." And I looked at her and I said, "Okay, but I'm 40 weeks pregnant. How are you possibly going to see anything?" And she said, "Well, I'm going to see a lot more now than when you deliver that baby, because that's going to be a whiteout." So it's really the amount of confidence and comfort that you gave me and so many women, and still do. So let's start out with something provocative. It's true that mammograms miss about 20% of breast cancers. And I've heard you say that women are dying unnecessarily because of outdated screening protocols and medical gatekeeping. Can you tell us exactly what women aren't being told about cancer detection and what hidden red flags they should never ignore, even if a doctor tells them it's probably nothing?
Well, I would be remiss if I didn't start out by saying, remember, you said mammograms may miss 20% of breast cancers. That is true, particularly in women who have more fibrous, dense breast tissue, which I'm sure we're going to be talking about very shortly. But that means that mammograms detect 80% of breast cancers or more. And I do want to say that mammograms remain, even despite many evolving and advanced technologies, the primary imaging modality for early detection and diagnosis of breast cancer. And in fact, even to this day, the only imaging test proven by not one, not two, not three, but six randomized control trials to decrease the death rate from breast cancer. And just an observation in my over 30-year career, the treatment of breast cancer because of mammograms and early detection has shifted. I would say there's been this enormous paradigm shift toward, and I'm going to use a term we use now, de-escalation, because the majority of breast cancers that we find are early stage. Having said that, probably the single most important thing I can say together is that women should know that having a negative mammogram does not mean you don't have breast cancer or that you will never get it. It simply means that this screening test has not detected breast cancer. Not that it isn't there. So women should never ignore what you call red flags, or I would say any change in their breast should never be ignored. A lump, skin retraction, nipple discharge, a large red nipple. I mean, we know, we shower, we look in the mirror, we see our breasts. I think that women, generally speaking, are very in tune with their bodies. Never ignore a change in your breast, even if you've had a negative mammogram.
And Harriet, I remember, because I have dense, or had, because I no longer have breasts, dense breast tissue. Even that first mammogram, you added two things. One, you added the ultrasound, but over the years, you also talked about how you were using AI. And this was, I mean, easily 15, 20 years ago, how you were using AI to increase the efficacy of these screening technologies that were already really good. Could you explain that more to people, and why some people get an ultrasound also and why some don't?
I think women should know that mammograms, believe it or not, are not equally effective in all women. How well a mammogram alone is able to find and see breast cancer is dependent on several things. Probably the single most important thing is that type of tissue you have under your skin. So the skin envelops our breast and gives it size and shape. And under the skin, the type of tissue varies in all of us. There are four basic categories, and the first sentence of every mammogram report is a description of the type of tissue that you have, from fatty, which is sort of a black background, to average wispy tissue, to heterogeneously dense. I describe that as you take cotton balls and sort of fluff them out and put them in the breast. That's heterogeneously dense. That's you, Joelle, and me. And then extremely dense, almost a complete whiteout. What determines the density or how fibrous your tissue is? Well, for the most part, it's a genetic trait from either your mother, or if you're like me, your father's, because I've seen my mother's mammogram, side of the family. So it's genetic, and there's sort of the double whammy for reasons that we don't know. Women who have more fibrous, dense breast tissue are at elevated risk for breast cancer. It's an independent risk factor. For example, those of us that have dense breast tissue, and by the way, it's common, it's 50% of us, are at higher risk than our girlfriends that have fatty tissue. And we're at higher risk, and mammograms may not detect breast cancers hiding in that fibrous breast tissue. So we may need to supplement the mammogram with another imaging modality. For example, for many women, a mammogram alone is not enough, especially women who have dense breast tissue. Yes, I was an advocate for supplemental screening maybe 2 decades before the state and federal mandates to inform women about their breast density, learning very early in my career from humbling cases of mammograms alone missing breast cancer. So ultrasound is what we call additional or supplemental breast imaging in addition to the mammogram. There are other imaging modalities, particularly MRI, in high-risk women that are really important to know about. But I do hear from women all the time with dense breasts that, oh, I don't know why I need to have a mammogram. Mammograms won't show anything. I have dense breasts. Remember this important fact: 80% of breast cancer we can detect on a mammogram in women who have dense breasts because they form calcifications or areas of architectural distortion. A mammogram is the only way to detect those very subtle findings, but like I said, is not enough. So that's why we do ultrasound, particularly in women who have dense breasts.
And it sounds like the conversation to have is to ask your doctor, what type of breast tissue do you see? And what does that mean given my particular risk factors and my type of tissue? What should the type and timing of my screening? Dr. Laura Esserman is one of my doctors as well, and she's very big into the wisdom study because they're trying to be personalizing even the screening of risk as well as when we start engaging in breast imaging. And of course, all women at all times, as soon as you have breasts, should learn to touch their breasts every month and be aware of what their breast feels like so that if there is a problem, if there's a change, I joke that I had a frequent flyer global elite status at your breast imaging center because I felt or saw anything. And the answer was, come on in, we need to do some screening.
Absolutely. Never, ever ignore something you're concerned about. We would rather see you, and if everything is normal, you know, that's a great day. Than
Yeah.
not see you and have any woman ignore something she's concerned about.
Well, and besides the fact that I always loved the opportunity to see you, I used to call and I was doing scanning for the audience twice a year because Harriet had me doing mammogram and ultrasound, and then 6 months later doing MRI, so that every 6 months somebody had scanning eyes on what was going on beneath the surface, in addition to monthly touch yourself. The one of the things I would do that ended up playing into my whole cancer treatment is I decided that the days I went to the breast imaging center were days to celebrate because they were days almost every time where I definitively knew on that day I did not have cancer. And why shouldn't one celebrate it? So it was my half year I don't have cancer day. And it was always a good day. Plus I got to see you. So you mentioned some hard won lessons early on. And one of the conversations with you I remember is right as we came out of COVID. One of my every 6 month scans got pushed because you weren't allowed to scan anybody. And it wasn't, I didn't have cancer that day. It was a good day. But you and I talked during the ultrasound. And I remember you telling me how frustrated you were because of the number of tumors you detect every week. So I'm wondering if you would talk about that women didn't detect themselves. So I wonder if you'd talk about that and those hard won lessons that have deepened your passion for what you do.
Gosh, breast cancer is just, for whatever reason, extremely common. As we all know, it is the most common cancer in women. It is a global health problem. Did you know it's the most frequently diagnosed cancer in young women, ages 20 to less than 50? Just in any center that does a large volume of screenings. In women that got called back for additional reviews for which biopsy is recommended, and the daily thing, women coming in with lumps and changes in their breasts, it is humbling every week the number of phone calls that are made. I call all biopsy results, whether it's that your biopsy is benign, great news, as most are, or that your biopsy does show cancer. And most of the time it's early stage, and we have a thoughtful conversation and then talk about next steps and plans and moving forward with that diagnosis. But the concern during COVID was we had halted screening for several months. I can remember it was Friday, March the 13th, when we decided to close the center, and I believe we reopened May, perhaps mid-May. So just a couple of months, but thinking about those, so many women not coming in for their screens and the consequences. I think we're still learning, and we will learn as the years go by, the consequences of halting screening for several months. But breast cancer is common, and I do see women every day that are quite annoyed that they're here. No one likes to have their breasts squashed while having a mammogram. I just had mine last weekend, so it's quite real to me. I can still feel my mammogram today. And they say, I don't know why my doctor wants me to have a mammogram. And here's what they all say: no one in my family has breast cancer. And while family history is an important risk factor, and certainly having a genetic mutation that predisposes you to breast cancer, which is about 10% of women diagnosed, most women, I would say about 75%, where I work, diagnosed with breast cancer, have no family history or any risk factors. They are completely shocked with the diagnosis. They've had 3 children, they've breastfed, they exercise. And that's because the greatest risk for breast cancer is having breasts and getting older. Having said that, another important point, I want everyone to know something we are observing. We are observing increased incidence of breast cancer in young women. My youngest patient I've diagnosed with breast cancer was this year. It was a 21-year-old. And we are seeing an increased incidence of pregnancy-associated breast cancer in women during pregnancy or that year that they are breastfeeding. And it's thought to be due to the fact that women are putting off childbearing till their mid-30s, early 40s, and that's just a reality that we all should know. And Joelle, you brought up something really important just in the opening statement. The American College of Radiology has changed appropriateness criteria for screening now to include pregnant women. So if you are pregnant and you are of screening age, for example, you're 40 and you're pregnant, or you're 32 and you're pregnant, and there's a reason for you to have early screening due to a family history, due to a genetic mutation, women should know that mammograms are completely safe to you and your baby and are completely safe while we are breastfeeding. So I wanted to make that important point. We are now doing screening mammograms in women who are pregnant just for that reason.
That's great. I didn't know that they had changed the screening profile and the care with which I was treated. I was scanned when pregnant with my second. I'm pretty sure I was scanned while pregnant with my third. And my family's genetic, because we're in that 10%, we're triple
Yes.
negative, and there isn't necessarily a correlation with the pregnancy, but it's still, there's a higher risk when hormones are surging through your body. I wanted to ask you on breast tissue, Harriet, does your density of your breast tissue change as you age? Or if you're born with heterogeneous, like I have, like you have, that's it for life, that's what you got?
So there is this myth, and it's a prevalent myth, that as we get older, our breast tissue gets fatty. And that has not been my observation. Of course, generally speaking, younger women have denser breast tissue. And as we go through menopause, there can be some what we call fatty involutional changes. Through menopause and postmenopause, our body changes. There is a deposition of fat in the central portions of our bodies,
I
our back. You know
noticed.
what I'm talking
I
about.
noticed.
So there can be some fatty involutional changes. However, in my observation, and I've been doing this for over 30 years, women who have really dense breasts or extremely dense breasts have it when they're 45 and have it when they're 78. I see elderly women in their 80s with extremely dense breast tissue. Like I said, it can be, for most of us, it's a genetic trait, sort of like the color of our eyes, type of hair, which may alter certainly during pregnancy and breastfeeding. That's when the breasts are very proliferative and very, very dense. If you gain weight, lose weight, they can have a slight change in your breast density. But for most women with really dense breasts, it is that way for their lifetime.
Thank you. That's very helpful because I believe there was a new set of guidelines or regulations that were issued in the last year or two requiring doctors to tell patients what kind of breast tissue they have. Can you talk a little bit about that?
Absolutely. So you may have heard there were many states, about 38 states, and the District of Columbia had state mandates to inform women of their breast density. It started in Connecticut, which led the pack in that legislation, and then it went across the United States. Last, I think it was March 2023, there was a federal mandate that became law, took effect in September in 2024. Every mammography facility needs to inform a woman in the report, their mammogram report, and in the letter that they get, whether or not her breasts are dense or not dense. So it is, you have to do it, every mammography facility. So every woman is informed about whether or not she has dense breasts, which is a good thing. Women
Yeah,
need to be informed and empowered and ask questions.
I think that's so important. Again, you're the quarterback. Like you, the patient, are the quarterback of your health journey. Even in the arena of cancer, where the team gets filled with specialists who are awesome, they are great, but no one is as focused on your health as you. And you have to know information like your breast density, like when your last scans were, if you're still menstruating, when your last cycle was, in order to provide that to this team of fabulous specialists so they have what they need to care for you.
Be an advocate for yourself and others.
Absolutely. So I wanted to ask you, my type of cancer was invasive ductal, which is, I think, the most common of the big breast cancers. A number of
Yes.
the women I interviewed had lobular breast
Hmm.
cancer, and it sounds like there's some challenges in screening with lobular. So, what is the state of the art now, and what should women know just to ensure, again, they're taking their health seriously and they're an advocate?
Yeah, absolutely. Let's start with triple negative breast cancers. Triple negative breast cancers can be some of the most aggressive breast cancers. And just to put it out there, breast cancer is not one disease. It is, as you know, very heterogeneous, very many different types found at different stages. Triple negative breast cancers tend to be the most aggressive. Women who have certain genetic mutations like BRCA1 tend to get triple negative breast cancers. Black women tend to get triple negative breast cancers. Young women tend to get triple negative breast cancers. They can be very, very hard to find in dense breasts. However, there is one way in which they light up like a light bulb, and that is if you give contrast through the vein, either from an MRI or a relatively newer, though not new technology called a contrast enhanced mammogram. That contrast may be the key ingredient to finding the most aggressive type of breast cancers early, and that is life saving, and that's triple negative. Now, invasive lobular cancer. So there's two main functional parts of our breast tissue. Those of us that breastfed know that when you squeeze your nipple, milk does not come out in one opening. There's anywhere from 10 to 18 duct orifices at the nipple. Each of those openings branch like branches of a tree to supply a segment of the breast. At the very distal part of that branch are lobules, grape like structures lined by cells that make milk when we're breastfeeding due to a hormone called prolactin. So, 90% of breast cancers, for reasons that I don't think anyone knows, are ductal, invasive ductal cancers. And generally speaking, they show up on mammograms, they form calcifications. They're irregular, they're spiculated, architectural distortion, and they enhance with contrast, most of them. Invasive lobular cancers can be very, very tricky to detect because instead of forming a mass or a ball in the breast, the cells can sort of travel along normal structures, and it can be a very subtle asymmetry, architectural distortion, very subtle change, but it can create a lump. We miss invasive lobular cancers at times because they are so subtle, but women can often feel them. And again, that's why we say if you feel something, let us know because we need to do more imaging. Sometimes an ultrasound finds it, sometimes doing an MRI. Sometimes no imaging exam shows an invasive lobular cancer, and the way to make the diagnosis is biopsy a lump even if you're not seeing anything. So that's the tricky thing about invasive lobular cancers. Because they are difficult to detect, they can be more advanced or larger in size when they are finally found.
Yeah, one of my colleagues who's in the book, it was a shadow on the mammogram. It just kept showing a shadow. And what was a little bit irritating, actually, for me, it was infuriating, was that she kept telling it's nothing. And the number of young women, Harriet, that had said, I was told it was nothing. You know, Tracy was told that, my sister. But a lot of, and I don't know if that the doctors just think there's no way, it's too uncommon, they're not specialists like you are, but how do we deal with this reverse age discrimination against women in their 30s and early 40s because they were too young for screening by the screening guidelines? They didn't have a family history, they weren't high risk. And, you know, there's still people who say now we should wait till we're 50, except breast cancer is more aggressive in younger women because cells are replicating faster because they're younger, they're healthier.
Right. Absolutely. I think that with the increased incidence of breast cancer in young women, I think attitudes are changing. And as a physician, I don't think any symptom, any lump in a woman should ever be ignored. And no woman who feels a lump should be told it's nothing because it's something. She's feeling a lump, so it's something and it needs a diagnosis. Now, having said that, a very common lump is just a normal fatty lobule under the skin, but that's something. So if the mammogram is negative, you have to put your fingers over the lump, do an ultrasound, make a diagnosis. So I think women of all ages with a lump, including teens. I have seen some teens with lumps. No lump should be ignored. It needs a diagnosis one way or another, either that it's benign, it's a fatty lobule, or it's a fibroadenoma or a cyst, or it needs to be biopsied. And if a woman is hearing that and feels uncomfortable, get another opinion. Or one other important point is where you go to have your mammogram and your breast imaging matters. You really want to go to a place that is ACR accredited as a comprehensive breast imaging center, accredited in mammography, ultrasound, stereotactic biopsies, MRI, with physicians that are expert trained, either with fellowships or many, many years of experience, and dedicated technologists. Because at those centers where we're seeing high volumes of patients, we have seen breast cancers in young women, and we know never to ignore a lump or a nipple discharge or any change in a breast.
And how would someone know or find an ACR, an accredited breast imaging center, particularly if they sense something and they want to go to a place that is full of the best technology and the best, most experienced doctors?
So Google the place. And if it is an ACR accredited comprehensive breast imaging center, it will say it. It will have a logo. When you go into the center, you will see a plaque. Or you can call the American College of Radiology, but make certain that you are going to such a center. Plus, you really want to have access to what we call multimodality imaging and screening, as we talked about mammograms, breast ultrasound. Breast ultrasound really needs to be done by experts. It's the most difficult thing we do. Access to MRIs, access to minimally invasive biopsies and procedures, and then access to, I know what we have experienced together, a multidisciplinary breast care team to take care of you as in a very collaborative way with continuity of care, which includes breast surgeons, breast oncologists, radiation oncologists, geneticists, nutritionists, nurse navigators, the full gamut of breast specialists.
And I'll even add the psycho-oncologist for the mental health, because when you say to someone, you've made so many of those calls, you didn't actually have to call me, but you've made so many of those calls. And for most people, it's out of the blue and their world rocks. I mean, that's why I wrote my book. It's why I'm doing
Right.
this podcast, to say, like, hang on, there's a lot more information. And I had a very aggressive, as you know, that's my family's type. And even there, you don't need to start treatment the next day. So, can you explain what you mean by aggressive versus less aggressive, and what that means as people are thinking about, do I have to have surgery tomorrow? Should I start chemo tomorrow?
No, but a lot of women wish they could. But just to add one thing to your point, probably the hardest thing I do in any given day is to call a woman to tell her that her biopsy shows a breast cancer, and we talk about it, and hanging up the phone is very, very difficult because the roller coaster of emotions, the shock, the letting the family members know. When I hang up that phone, I never know what's going on a moment later, or 5 minutes later, or 10 hours later. So I just wanted to share that that's just the hardest thing that I do. I always give my cell phone, and then fortunately, I have a nurse navigator. So I let her know that I made the phone call, and she does the follow-up phone call. And then, the team will call and make sure appointments are scheduled, questions are asked. But that's just the hardest thing I do, hanging up that phone after a breast cancer diagnosis.
I do want to tell you, and I don't know if it's because you and I talked about it, but I actually called or used the My Chart online and sent a note to the breast surgeon who did call me, just to tell her that I knew it had to be hard for her, and she did it with such kindness and support. And I just wanted her to know, and I wanted to know, like, I'm on the right path and I'm okay, but I wanted to thank her. And I guess it never happens. People don't call to say, thank you for giving me some of the worst news I've ever heard.
That probably just meant so much to her, Joelle, that you did that. I don't think that I've maybe sort of a year later after the treatment, when because I am so blessed to be able to see my patients and follow up year after year after year. And I'll just mention that when I first started 3 decades ago, I had a woman come in with inflammatory breast cancer, and she was alive and well when I moved on from my prior job two and a half decades later. So what a change that is. Now
Yeah.
I remember your question. With a breast cancer diagnosis, does something have to be done tomorrow? No. Even with the most aggressive types, you've got the diagnosis. You have time to gather information, see varying physicians, have multiple consultations to decide where you feel most comfortable placing your trust for your care, because that's a long-term relationship for the breast cancer treatment and then follow up thereafter. So there's always time. Breast cancer gets treated in very many different ways. Sometimes hormonal treatment is started. Sometimes chemotherapy is the very first thing. Sometimes it's surgery. So there is definitely time to make sure you have gotten several opinions and spoken to several people and know and be confident that you're on the right track for your treatment.
Well, and I think the other thing that happens during that time, that window when you're gathering the team and figuring out your path, is you're also gathering more data. And because there are so many variables and so many varieties of breast cancer, more data actually allows a much more bespoke treatment plan that can be highly effective, less toxic, more in keeping with your overall lifestyle. So I was able to restrict cancer to 1 day a week for my entire treatment, other than when I had my surgery. Then it had the gall to invade multiple days. But that was because we took our time and we had data that showed I was eligible for a less toxic but weekly treatment. That's not right for everybody else. And my sister, who had the same pathology, because she'd had cancer before, she needed a different treatment pathway. So I often tell people when I talk to them, they're like, well, how were you treated? I said, it really doesn't matter. I mean, I'll tell you, but what matters is what's specific about your tumor, your health, your life, and your team.
Right.
And that's how you're going to get the right path.
And do you have a collaborative team
Makes sense.
that works together for your benefit? That's probably the most important thing.
I think that's right. All right. Now, we talked a little bit about the ACR Comprehensive Breast Imaging Center, and you have been on the cutting edge of breakthrough screening technologies for decades. I mean, you didn't take the bait when I talked about the AI, but I want you to talk about that. I want you to talk about all the emerging detection methods, but what you're most excited about that could fundamentally transform how we detect and treat this disease. Is there something game changing in the works, and what's
Yep.
keeping it from getting to prime time?
First, I think I'm going to say, because I've been doing this for 3 decades, that probably the single most important technology that I will see in my career is 3D mammography. And every single woman should be having a 3D mammogram. It is now, I'm just going to say it, the standard of care. Why is that the most important technology in my career? Simply put, it is a significantly better mammogram for millions of women getting mammograms. So it increases the breast cancer detection rate while at the same time decreasing the recall rate. And with the next generation of 3D mammograms, the radiation dose is equivalent to 2D. 2D is over. It just is a better mammogram for screening. So that's it. I'm so blessed to have seen that in my career. Having said that, it's never enough. Mammograms are not enough. We can talk about AI, and I'm going to admit to you and everyone who's watching the podcast, I am a human being. We all are. Doctors are human beings. I get tired. I get distracted. Things come into my mind while I'm reading mammograms, and mammograms can be very image intensive in terms of the information. We're looking at the mammogram and we're looking at single slices through the breast, traveling side by side, up and down. I love AI because it is a robust way. Computers aren't human, they don't get tired, they don't get distracted. It is a robust second read. And I'm so pleased to have it. And that's a hugely important technology. I think it will only get better as time evolves. So I am not fearful about losing my job. I just think AI will make me a better doctor. Even a negative mammogram, when I'm reading a screening mammogram and it's negative, before I put that report out, I sort of hover, I look again, I make sure I check the nipples, the armpits. With AI, the computer, I know it's seeing everything everywhere. And when it says negative, and I think it's negative, I feel like, okay, I'm moving on to the next case. So I think that's an important technology. And I told you early on that I think, especially for the most aggressive tumors in, in women with dense breasts, and sometimes not dense breasts, the most important ingredient in finding them is actually contrast. Why? Because the most aggressive tumors, the very first thing they need to do, because they're growing so fast, is bring in vessels. And those vessels tend to be abnormal and leaky. So if we give contrast and we do an MRI, they tend to be very, very bright. But as MRIs are very expensive, they're very resource intensive. Even abbreviated MR takes a lot of time, and there's a lot of competition for the MRI magnet. I think an evolving and very important technology is a contrast enhanced mammogram. It's a mammogram, But right before the woman has her mammogram and IV is started, we give the contrast. We do the mammogram just like we always do, but we get the added information of areas that show up because they're enhancing. And I think that's a way to really increase the detection rate and the power of a mammogram as an alternative to an MRI. I think at
Interesting.
the current time, it probably is AI and the increased utilization of contrast, either with MRI or contrast enhanced mammography.
Really interesting. I think one of the benefits of having a bilateral mastectomy is I no longer am eligible for mammograms. So I don't think I ever had a 3D or a contrast enhanced mammogram, but they sound like incredible technologies. And I am hopeful for my daughter, my niece, and all the women who have breasts that these are available. I did want to ask a clarifying question. You mentioned biopsies and stereotactic. You used the word stereotactic, but in my experience, there were two types of biopsies, and I think there's more. But what is the difference? Why does sometimes you do a core needle versus a fine needle, an ultrasound guided versus an MRI guided? Those are the ones that
Yeah,
I recall.
great question. So, generally speaking, there's different tests for imaging the breast: mammograms, ultrasounds, MRIs, contrast enhanced mammograms. Any of those tests may show something. So, generally speaking, we do the biopsy using the modality or the test where the abnormality is seen the best. For example, or whatever is easiest. For example, let's say you have a mass in your breast that was detected on the mammogram. It's seen very well on ultrasound. I'm going to do an ultrasound guided biopsy. But that's not always the case. Sometimes the mammogram shows something, the ultrasound is normal, but the mammogram is not normal. So if the ultrasound is normal and the mammogram is not normal, there is no permission to ignore the mammogram finding. Then you do what's called a stereotactic or tomosynthesis guided biopsy. Generally, the woman is sitting upright or laying down on the table, and it's a mammogram, and most often a 3D mammogram that's used to localize the lesion. If it is something seen on MRI, which happens very commonly because we are utilizing MRI, especially with risk reporting, telling a woman what her lifetime risk for breast cancer is, and using that risk to inform what I call my other passion, personalized screening recommendations. We're doing MRIs in women who had normal mammograms and ultrasounds. If the MRI shows something, I'm going to do a biopsy under MRI using MRI guidance. So that's generally how biopsies are done. Almost all biopsies, Joelle, are core needle biopsies. By that I mean a core is a very small surgical specimen. It's like a little piece of spaghetti. If you imagine spaghetti, it's like a little piece of a spaghetti. That's what a core is. It's surgical. And those are the most accurate because the pathologist makes slides of the tissue itself. An FNA is an aspiration using a skinny needle to aspirate cells, but the cells are not in the tissue in which they were living. They've just been taken out and aspirated. And that is less accurate overall. There's a greater chance of a non-diagnostic biopsy. Some of us, I never do FNAs. I always do core needle biopsies. But I do want to mention something because it's just in my memory at the moment that was very important to me that I learned reading your book that I already knew about, but very, very important. I've given talks about this and I share this with my colleagues. Giving women sufficient anesthesia for biopsies is absolutely, positively key. And I think women generally are under anesthetized. I don't know why. I've had biopsies myself and I could have used more. And so I use, and you spoke about that, your
Yeah, it was
experience
awful.
with biopsies. We do not want women to have an awful traumatic experience and have post-traumatic stress disorder from a breast biopsy. Adequate numbing of the area is absolutely key. So thank you for reinforcing that for me as a physician with my patients.
Yeah,
For
I
me,
remember the doctor who did it. He's like, don't jump when you hear the sound because there's a sound with the core needle. And
yes,
definitely was under anesthetized because the sound wasn't the problem. I had to not jump from what was painful. And I've had lots of biopsies. You've done lots of biopsies on me, and I would not have described any except that one as painful. And I don't think women should be afraid of them, even if it is a little painful. And ask for more anesthesia, like ask to be numbed. You can advocate for that, but the biopsy is how you get definitive information about what it is. So there's no it's nothing unless the biopsy comes back and says it's nothing. That's wonderful news. I got that news many times.
right, right. So that's the difference between the two. Fine needle aspiration is a skinny needle trying to aspirate cells. The core is the snapping noise, sort of sounds like a staple gun, and it's actually taking a piece of tissue.
I remember that noise. In your decades of practice, what's the biggest mistake you've made with a patient and what did it teach you? And I'm asking, I think you're fabulous. You're wonderful. You walk on water as far as I can tell. But I believe that people who admit their mistakes are ones we actually can trust with our lives because they're always learning.
We are all human. Physicians are human. Mistakes happen, complications happen, or lapses in judgment happen. So there's various things. I think every physician, it's a painful way to learn, but we do learn from our mistakes or lapse in judgment or misses, things that in retrospect we could have found or seen, but we didn't for various reasons. And the one thing about being a breast imager is because I'm recommending biopsies, doing biopsies, getting the results, seeing the patient year by year, I'm getting constant feedback, and all of us are, in terms of our performance. And boy, do you learn when you've missed something. In terms of mistakes, all human beings make mistakes. I do remember probably the biggest mistake of my career. And one of the challenges is when patients are referred from outside offices or institutions for biopsies. And early on in the breast MRI experience, there were very few centers doing MRI guided biopsies, and Mills Peninsula was one of the first when I started doing them. So there was a woman who was referred from about an hour and a half away with an outside CD, and it was a very difficult MRI guided biopsy, which I did, and it went well. And the next day, I was reviewing the course of the needle and the biopsy, and I realized that I had inadvertently biopsied a lesion, but it was not the most suspicious lesion. I had not biopsied that. And I remember as soon as I realized, I broke out into a sweat. My heart is beating out of my chest. I took a deep breath and I immediately picked up the phone and I called the patient. And I said, we did the biopsy yesterday and the biopsy results were benign, but that was not the lesion I had intended to biopsy. You have to come back and we'll do another biopsy of the area. And the response that I got was so shocking to me. The response was, thank you so much for calling me and letting me know when you want me to come back. And here I thought she would understandably be so upset about having to come in and do another procedure. She was so thankful and grateful that I called, that I was honest, let's do it again. And she did come back again, and we made a cancer diagnosis. And I think mistakes do happen, and it is our job as physicians to call patients immediately, let them know, and let them know what you're going to do to rectify that mistake, what needs to be done next. And that actually changed my practice also, because now when patients come from the outside, I review all their imaging ahead of time. And in fact, it changed my practice on a daily basis, because I come into work about 30 to 45 minutes early when I'm doing procedures to review every single procedure in every single patient before she comes in. So I'm reminded, I take notes, I plan my approach, because no one wants to biopsy the wrong lesion. And it happens. But I think planning is absolutely essential. So that's how that mistake changed my practice. And that's probably the biggest mistake I've made in my career,
Well, a couple
which
of
is
things.
I haven't had complications,
Sure.
which is a mistake.
So I bet if I were to have that woman on the podcast, her version of the story would be something like Dr. Borofsky saved my life because she came back and she found the cancer. And that all that you would have is gratitude because you owned it. Mistakes happen, you owned it, you fixed it. And I'm going to guess, Harriet, I mean, you've trained and taught a lot of people how to be breast imaging experts. And this learning experience of yours became part of a routine that I'm sure you have taught to every doctor that you have worked with since.
Absolutely.
So not
Yep.
only did it improve your practice,
Mistake. Yes, you're so right, Joelle. I have shared that mistake with others as a way of not just letting them know it's important to review things before you do it, but if you do make a mistake, as you say, own it, call the patient, be honest, rectify it, always do the right thing. I come to work every day with those words right on my shoulder. Do the right thing. It's very basic, but absolutely crucial.
I think that's right. So let's do a little lightning round. I'm just going to go quick. We'll go quick back and forth. First, three most overlooked physical changes that women dismiss, but you know they need to come in for screening.
Things that they dismiss, I would say skin retraction,
What is
nipple
that?
change. That's when your skin pulls in when you lift up your arm. Like anything that's pulling in, the nipple being pulled in, nipple redness, any lump under the arm, come in, get it checked out.
Okay. What is the single most effective a woman can do besides standard screening to dramatically increase her odds of surviving breast cancer if she's diagnosed?
Positive attitude. Surround yourself with the most talented team and highly experienced, and be healthy. The other thing that's really important is, there are ways to sort of live a healthier life that may decrease the chance of getting breast cancer. Watch your body weight, have a BMI, body mass index of less than 25, limit alcohol, exercise regularly. Studies have shown that if you do all those three things, it decreases the risk of breast cancer by 22%. Like, wow. So that's really, really important during treatment. Be healthy, positive attitudes, surround yourself with a really talented team that you trust.
And as much as those can help you prevent breast cancer, the best way through if you do get breast cancer is be really healthy at the start because it gives your body the best resilience. Okay, question number 3. There are communities where people are afraid it's disrespectful to advocate, to challenge their doctor. They are sometimes in communities of color or different socioeconomic. So, what do you say to people who are scared or feel that their doctor will be angry if they advocate, challenge, or question?
A doctor should never be angry. A doctor is there to listen and support your health. So, probably if you're worried your doctor is going to be angry, it's probably time to find a new doctor, because it's a connection, it's a relationship that that goes both ways and with mutual trust. So, really shouldn't be seeing a doctor you're worried is going to be angry at you. And as we started out saying, every woman has to be her own advocate for her health. And that means not being afraid to ask questions and certainly not being worried about making people angry when it comes to your health.
Okay. If I gave you a magic wand and you could change one thing in the US healthcare system without worrying about politics or blowback or anything else with regarding to breast cancer screening, what would you use your magic wand to do?
That is easy. There is a super important legislation going through the House of Representatives, Find It Early Act, and that would mandate insurance companies to cover all aspects of screening in high risk women and women with dense breasts, because right now there is a major issue with disparity in care and access and affordability. And that would have the most enormous impact. And I hope I see it in my lifetime. Governor Josh Shapiro in the state of Pennsylvania has done it. Bipartisan legislation mandating insurance companies to cover supplemental screening in high risk women. So we can do it. And everyone should be calling their representative and making sure that that piece of legislation passes. Find
So
it
if I
early act.
so if we can find the link, I'll put a link in the show notes where people can automatically click it and reach out to their respective representatives asking them to support the Find It Early Act because this is not a disease that needs to be killing women.
Right.
So,
And all women should have access to what they need for screening. As we were talking about early on, for many women, a mammogram alone is not enough.
right, right. All right. This has been fantastic. I've learned. I love talking to you because it's always delightful and happy, but also so thought provoking. So I really
I
appreciate.
learn from you, Joelle, every time.
Well, and the thing on the positive attitude, I wrote about it in the book, but the idea of happiness tripwires includes how you engage with your medical team, right? And you don't have to be happy all the
Absolutely.
time, right? You don't have to be happy all the time because no one's happy all the time. And
You can't
cancer's a
be.
drag. Cancer's a
Right.
drag. There's not a, it's not a rah rah time. But, building a relationship with your medical team, with your doctors, sharing what's going on in your life. You and I used to talk about your kids, grandkids, my kids, and that was just part of the
Right.
relationship.
Right.
And I feel very blessed that you were my doctor for so many years and that, when I did get that unwelcome call and I reached out to you, you were one of the people that recommended me to the team that was the right team for me. So I'm
So
just
glad.
so appreciative.
My pleasure.
All right, everyone, let's help Dr. Harriet Borofsky out and let's all support the Find It Early Act so that her magic wand works and we can give her another one. Get the
Thank you.
mammograms you need, the screening you need, know your body. And if we can't prevent breast cancer, and I do hope someday we'll be able to do that, I did have one more question. One of the guests I've had on is a leading proponent of liquid biopsy as a
Mhm.
complement to
Mhm.
standard radiological screening. What's your perspective on the role of liquid biopsy as part of this process going in the future?
I'm hoping, Joelle, that someday, perhaps not our daughters, maybe your granddaughter, maybe my great granddaughter, that the screening test will actually not be an imaging test for all of the imaging imperfections, but the screening test will be a blood test. And the ability to detect cell free, cancer specific DNA will be the way in which we find breast cancer. It would have to be very specific because you wouldn't want a test that says, well, you have cancer somewhere. Now have a good day. It would have to be very specific for the type of cancer, and that's the way we screen. So instead of doing population based screening, as we do now for all women who have breasts, we would probably be screening those women or imaging those women who have a much higher likelihood of having breast cancer because cell free cancer-specific DNA was found in their blood. There's intense research. We were involved with the STRIVE study when I was at Mills Peninsula, and I think that will be a reality, and it's very exciting.
Yeah,
Probably
right.
not in my career, but that's very exciting.
Yeah, I think there's a bunch of challenges that we talk about on the episode with Dr. Peter Kuhn, but
Mhm.
it is exciting and complementary because even if you had a specific blood test that said it's breast cancer, even if it's breast cancer of this type or what have you, it doesn't tell you where. So then in complement, the radiology team, people like you are actually understanding where it is and starting that journey of gathering the data that's needed for a personalized treatment plan, personalized
Right.
screening, personalized treatment. It's going to be
Very
it's going to be a
exciting.
cool future someday.
Yeah.
So, all right, so the Find It Early Act is the magic wand. Engage with your doctor, advocate, find out your breast tissue type, and then ensure you're
Absolutely.
getting the screening that goes for with your breast tissue type, which it sounds like is your type for life. So,
For the
it,
most part. And know your risk. I think risk reporting should be part of the mammography report, and know your risk for breast cancer should start when you're 25 to 30, because for some women, they need to start screening at 25 with MRIs and mammograms when they're 30. So know your risk. Talk to your risk for breast cancer with your doctor when you're 25.
sounds perfect. Harriet, thank you for spending time with me. Thank you for sharing your wisdom with everybody.
Delightful to be with you and to be part of this podcast today.
Great. And that's a wrap for Kicking Cancer's Ass. If you like what you hear or you learned something, please share the episode with everyone you know. The best way to help save more lives, more women, is ensuring more people are educated by people like Dr. Harriet Borofsky. Thank you. Hit subscribe. We'll see you for the next episode.